আপনারা সবাই কেমন আছেন? আপনারা সবাই কেমন আছেন? How are you all? I think you now understand. That is the case I am going to discuss. Ladies and gentlemen, if you look at this, behind the screen you are seeing the Twin Tower, and a lot of people have invested their hours to build this, and they are none but migrant workers from different countries. It is said that there are about 258 million migrants around the world right at this time. And out of that, in every 30 people, 1 people are residing outside their own birth country. So it's a huge issue. The issue is about the migrant workers. They are living in Malaysia, Singapore, Thailand, in the Southeast Asian region. And we found that out of that, 60% they do not have any document to provide. So the migrant workers you see around, mostly they will be without any document. But don't they have any rights to have access to healthcare? Don't we have our obligation to them? That's the inspiration I had during my stay in Malaysia, and we developed a platform. So the problem, you understand, the language, the cost, because the cost for the foreigners a little bit higher in every country they live in, and then the documentation. So we found what we can do for them. But the interesting thing is that most of them have a smartphone, what we have. And on top of that, they have a very good habit of communication behavior. After working hours, they talk to their friends and family using WhatsApp, Viber, and Imo. So they are very habituated in doing that. And on top of that, they spend money using the mobile phone, going to the different shops. So, and also they top up their friends and family back home, like you can transfer money from DTAC and top up your friends in Bangladesh or Pakistan. So this is a very, very impressive habit they have. So what we did, we built a platform where they can find their own native doctors and they can talk to them. So we have made it simple and easy for them to talk to their native doctors when they are in need. In this ecosystem, we have introduced, if you have traveled to Malaysia, you will find a lot of local Bangladeshi shops there. So we have selected them as our agents who actually giving them top up for our service, because at the back end we have developed an e-wallet, and also we are partnering with some payment gateways like Touch and Go and My Cash Online. We are in discussion. So that will be in service. So they top up there and they can talk to the native doctors right away with the help of our call center agent. I think we'll discuss more on question session. So I should leave something for question session where I can explain more because the time is short. And if you look at the social impact, it's, to me, it's a huge one. Because if you look at, there are 60% who are unable to get the health access right at this point of time. So we are helping them some or with the other way to get to know what their problem is. Because at this point, they don't know what is their problem. So we are breaking that barrier in the first way. And we are creating some job opportunities for different people because they also can become our agents. The shopkeepers also become agents. And the doctors have their option to get a new opportunity for income generation. And we have now starting to partner with clinics. Already we have 2 clinics as our partner. So what we are doing, in the first visit, the migrant workers are going there, and the follow-up we are doing with our platform. So they being habituated, and word of mouth, this, the confidence is being built throughout the community. And we are also helping the government to reach their health for all the ambition, the goal of SDG. Market size, I would say, is the whole world is the market, but we are starting with a small, with a big idea. We are starting with Southeast Asia, then we want to go to Middle East countries where there are a lot of migrant workers living. The competition, we have telemedicine service provider in Malaysia, in any other parts of the world also, but they are targeting the white collar people, but our target segment is totally different. And we think that first mover has an advantage, and we want to shake hands if the competitors are going to, go for something new. That's why I'm calling it competition can be our collaboration, and we can minimize that. In the business model, we have two products right at this moment, and we are charging 10 ringgit for one service and another for 35 ringgit. So this actually we are starting small, but I think once we have a momentum, this can be a big one, with even it can shoot out our expectations. We have a lot of stakeholders, mainly migrant workers, the doctors, the government. Because government, we have to work within the global, government legal framework. So we are following that. We are following the Telemedicine Act of 1997 for Malaysia. It could be different for other countries as well. And then we have payment integrators, as I said. So we are working with them to use their distribution channel to top up our subscriptions. We have a big team, a very experienced team, not big. I have 27 years of service experience, and last several years I have been working with telecom industry, Telenor, your data here. I was in Telenor Myanmar and Bangladesh. So I rolled out telehealth services in Myanmar and Bangladesh, and now I'm doing it in Malaysia. So I have confidence, and I have special passion for this base of the pyramid people. So I want to make it a success. And we have other three people who have their own skill, and the young who is actually doing the digital marketing, because the digital marketing we can reach anyone, anytime. And to share with you, in last week, with one promotion, I have reached around 6,500 people, and 1,200 people has reacted to my, this promotion. So which is actually promising. We have just started doing that. These are some of the pictures of proof of concept. And we are now arranging, this one is, this one is actually we are training our Bangladeshi doctors, and this one for migrant workers are talking live here also. So we see that seeing is believing, and so we are arranging different local events, what we call BTL type of activities. We are doing that so that they understand how it's being done, because even people like us, we don't believe in this, because touch and feel is a different thing. You are seeing a doctor, and then he or she is giving you a prescription, and you can look at it. But this one is something different. So we believe in that, and we are doing that. So they are really excited, and we feel, we are confident that it will be a success. So there are few market adapting activities going on. We are doing the events, we are registering them. So as of now, around 20,000 people we have reached about our program, and 2,000 people have registered for our services, and 600 people we have served. But to tell you frankly, there's all these 600, mainly we have served them without any cost. But to make this product, make their confidence level higher so that they can use it later on. And we are targeting to commercially launch it in this coming March. And the main challenge we have is funding. So far we have not have any funding. We are using our own money to carry on. And our program has been recognized and awarded in different by different organizations and also competitions. So we are hopeful that we'll have some something from somewhere very soon to start our program. And this is a novel initiative. I think every one of you in this room also will support me, at least mentally, if not financially. Thank you very much for your attention. And we want to be Uber of health in digital healthcare in future. Thank you so much. ধন্যবাদ সবাইকে.
Thank you for your presentation and thinking about like the unmet needs of the immigrant workers market. But I have questions about the value chain of this enterprise. I've been to Bangladesh, and I understand probably it's similar to Thailand that doctors have very limited time. They work in like 3 hospitals per day, maybe clinic after that in the evening. So how would you attract doctors to work for you? That's the first question. And when the consulting service already started, and if an immigrant worker is really sick and they need operation or anything after that, what would be your service after the consultation?
Thank you very much. I think it's very relevant questions. If you look at the time hours, we are 2 hours ahead of Bangladesh. And so we already, during the pilot, we have tried that how it affects our timing. So 2 hours before, that's why normally these people will consult the doctors after working hours. So working hours is basically 5 p.m. in Malaysia. So that time it is 3 p.m. in Bangladesh. And they are available from 3 p.m. because some of the doctors are not going to be occupied that time. So we have some sort of analysis from our local doctors there, and we have used that they can use their time. On top of that, like in Bangladesh, actually you were right that we have around 4 doctors for 3,300 people. So it's not enough, but at the same time, if you look at the scenario, the real scenario, that not every doctor is occupied. Especially out of the 100 doctors, 30 or 35% doctors are actually doing different location services. Like they are having one clinic, going to another hospital. This type of specialist doctors are less in numbers. So the young doctors we are targeting for these undocumented people, because they need the advice to know, to understand what is their problem is. So at the initial stage, we want to let them know that what is their problem and what they should do, like a OTC type solution and also advice. So there is our main target. The pain point is that. So we are targeting that. So we can solve that problem. But as we go along, we'll have different issues coming in, and we are trying to introduce AI, and we are in discussion with one of the universities in Malaysia so that we can develop the AI when you will understand that who are available during that time of period. So we'll have those, coming up within a touch of a button. Our people will be able to see who are available. And on to your next question, I just.
After the consultation, if you find out that somebody is very sick and needs like operations or serious treatment.
Telemedicine basically has a limitation. You cannot treat the emergency people over telemedicine. So they will actually, even for the emergencies, the doctors will be the right person to advise what to do. So that we will address. And in future, hopefully, we'll have other collaborations where we can assist them in sending ambulances or any other emergency, pool transport, who can bring them to the right point to address that issue.
Thanks for your presentation. I have a question about your pricing. So you put that it was 10 ringgit for an interaction. Is that a flat fee or is that a time-based model?
It's a flat fee at this point. And we don't want to make it a time-based because sometimes we have seen during our proof of concept that they start talking and they start loving it as well, because they, in the first times, so normally what we are planning to do now, if you are a first customer, for this service. I mean, first time you are using it. So you let them use it for 15 minutes. So we are targeting around 15 minutes because we have seen around the world, patient discussions normally on an average standard discussion is 15 minutes. So we are allowing around 15 minutes for a 10 ringgit discussion.
And then
these
just
are
cut them off, or?
Pardon?
Then you would just cut them off. You would stop.
Not really at this point, still not yet. But when we go commercially, we will have that system that it will cut. But it will give a message to them. It will give a tone, indication that notification that you will be dropped out.
My one is very short. So my question is, I'm a bit concerned about the logistics of prescription. So if you get a prescription for your doctor as a patient, what shall I do? And what are the institutional places where this prescription is a legal document? You know, how are you handling this?
Okay, thank you. There are two segments within the segment. One is undocumented and the other is documented. So to start with, we were addressing the documented more of. You know why? Because these documented people, word of mouth, they will say this service really works. Okay, for the documented people, under the Telemedicine Act of 1997 of Malaysia, it clearly explains a doctor who has a MMC certification, registration, that means Malaysian Medical Council registration. I think Thailand has a different one. And then annual practicing certificate, that doctor is allowed to issue a e-health prescription. So that is the legal prescription which they have on their mobile. So whenever they go to a clinic or pharmacy, the pharmacy is legally bound to give them medicine. So that is, we have already cleared with Ministry of Health. So and other telemedicine provider who are actually targeting the white collar people is doing that. So it is already in practice. So we don't have problem with that. On coming back to the undocumented people, we are not giving them prescription. We are telling it as advice. So they have the advice on their mobile, and if they need to get some prescribed medicine, we are trying to help them with others like pharmacies where we have partnerships to deliver them some medicine. But there is a legal issue in these cases. So the gray areas we have discussed with Ministry of Health, because they say that you are targeting an unreachable segment for us. You are doing a great job, but there are gray areas. We'll keep our eyes closed for now. But if immigration people catch, that is a different case. But I said another question to them. You see this mobile, are you not protecting them to use the mobile? Why not? Then you restrict use of mobile. If they can use my mobile, and this is a social service in another word, so they are supporting us. So we are talking at a policy level as well, how we can eliminate these gray areas, but there is a long way to go.
My question is probably similar to Christina. I have a problem with the ecosystem as a whole, because the stakeholders live in one country, the doctors in another country, pharmaceutical may be at another place. So there's a question of, like you mentioned, logistics and liabilities. Who will be responsible for what?
Well,
how easy it is to build this ecosystem?
The ecosystem is not easy to build. Like whatever we see as a product or a service all over the world, the back-end job is so tough, but you get it very easily, right? So our job is to make it easy for the subscribers. So what we are doing, even if the doctor is in Bangladesh or any part of the world, is a native doctor. So we have started with Bangladesh. We might start with Myanmar for Thailand. So the case is, once they issue the prescription, the prescription will be available to the mobile phone of the subscriber, and he can or she can take it to the pharmacy. And even we are in future, in few months time, we'll have pharmacy partnerships as well. So they have our links, so they will be able to provide the medicine right at the moment. And now there is a challenge, I can help you in that. There is a challenge that they live in some of the remote areas. So what we are doing now, in Malaysia already the pharmacies are delivering medicine to their customers' doorstep. So we are talking with some pharmacies to deliver the medicine to the doorstep of this. So we have sales agent, as you have seen. So they can supply there and they can collect the medicine from there.